I'm Managing Director of SARD. I won't introduce everyone that's here from SARD, but I'll introduce myself, and then I'll pass over to Brian, and I'll allow Brian to give a short introduction as to who he is and what he's going to show you today. So this is a session on team job planning. We've got an hour set aside for this. I'm going to talk for about 5 minutes at the beginning with regards to what the session aims to cover, and also to give you, if any of you don't know who we are, a little bit of information about the company, where we come from and how we operate. So in terms of the session itself, it will largely be demonstration side of things. At the end, we'll leave about 10, maybe 15 minutes, depending on how we get through stuff, for any questions that you've got. If you do have questions that arise after the webinar, please feel free to contact either Chris or Jan or myself or Brian, and we will happily talk you through or provide any answers after that. So it's not it's kind of a first look in terms of team job planning for a lot of you, and our approach to that. The system is going to be officially launched in November. I think it's towards the end of November. But before that, let me just give you a little bit of an idea of who we are. So excuse me while the screen slightly changes for a minute. So yeah, we represent a company called SARD JV, and we've been around now for 10 years. We had our 10th anniversary in January this year, so it's actually nearly 11 years. We cover a great number of sort of workforce products, and I'm not going to spend a lot of time talking through those. I just really want to give you a flavour of where we come from and how we operate, because I think it's really useful for those of you who don't know us. So, as mentioned before, the focus of this session will be on team job planning. In terms of the company, though, we are part NHS owned, and we have been for the last 10 years. We work with Oxley's NHS Foundation Trust, which is Mental Health and Community Trust, and that's where I originate from. Before I co-founded this organisation, I was head of learning and development there. Since we commercialised our medical revalidation product, which is where we started, we've since grown in a number of trusts that we support through various modules, to just over 50 trusts now. We look after about 50,000 users. In terms of how we operate, it's really simple for us, and it's so simple that it's really effective, which is essentially we concentrate on two core things: great customer service and great technology. Obviously, you want technology that supports what you're trying to achieve, that gives you the right outputs, that is easy and intuitive to use. But equally, when you start to deal with some more complicated issues, job planning being one of those sometimes for some individuals, and certainly around the team job planning arena, the idea of support is really key. We're not a company that sells a product and then kind of disappears and fades into the background to leave you on your own to sort of find your way through the system. Our commitment to customer service runs from really today showing you what we're doing all the way through potential purchase, and then continuing through to the end of the contract. One of the things we do on our current products is every single one of those 50,000 users has direct access to our support team. It's an internal support team. We don't push it out anywhere. We keep the knowledge within the company, and it's frictionless. So if you have a feature request, if there's an issue, if there's a barrier to the system, you can speak directly to us. So I mentioned the fact that our systems are intuitive. So this is the technical side, accessible and configurable. Now, I will mention here, Brian, who's going to take us through the team job planning system, is going to show you a demonstration of a system that we've been working in partnership with. So it will be acute focused, but I do just want to lay out now that this is not just an acute focused system. It just so happens that that's the arena we've been working in to develop it. So if you do have any questions, if you're from a sort of mental health or community trust about how it would operate in that scenario, then feel free at the end to ask those questions. I mentioned before that we have a number of different systems that we operate within, and the reason really for showing you this is not to try and sell you our other systems. It's actually more a case of when we build something, we build it in partnership. So all of the systems you can see on your screen at the moment and services that we offer, they have been built and created in partnership with other trusts, and this is no different in terms of the team job planning. I did also want to mention the idea of interoperability, because I think it's really important nowadays. NHS E&I, or E, I can never keep up with the name changes anymore. I've really been pushing for the idea of interoperability. So we work on open platforms. We have what are known as API endpoints on our systems. And really, in layman's terms, it's about ensuring that any data or information that you have in any one of our systems is accessible to be used in other systems. One of the best examples I can give you at the moment is we have a medical revalidation system, and we have an API link to an organisation called Think Learning. So essentially, once you complete your mandatory and statutory training in Think Learning, it automatically appears in your medical revalidation portfolio of evidence, and vice versa, your appraisal compliance will show up in Think Learning. And we have a number of these sort of links on the go at the moment that we're developing. So if you have any questions about what happens with your data and so on and so forth, please feel free to ask. But interoperability is really key for us. I mentioned we've got 50+ clients. We work geographically in quite a diverse way. We look after 7 of the 10 Shelford Group trusts, so trusts like Guy's and St Thomas's, King's College, UCLH, Manchester, Newcastle, in various guises. They don't all use all of our modules at the moment, but there is a spread across those. The biggest trust we work with is Manchester in terms of number of users, and that's 2,000 doctors, all the way down to some of the smaller community trusts where you may have 30 or 40 consultants. So this is obviously with team job planning, a team-based approach. So Brian will explain a little bit more with regards to that. But just to give you an idea of the sorts of organisations we currently work with. And I won't go on too much about this. Suffice to say, there is a traditional support model, which is you have a central administrator, all your queries go there within the trust. They then speak to the provider, and they either deal with the queries or they put it on what's called a roadmap of development, which can lead to some level of frustration. We don't do that. Ours is continuous feedback and continuous development. So when the system we show you today is not the completed article, and the reason we understand that that's not the case is because we've had 10 years of experience of continually building systems up when processes change, when policies change. All of these things are really important. So we're agile. We make sure that we continuously update our system to meet the requirements of organisations. And likewise, each of the organisations that you represent today will work in a slightly different way. There'll be a slightly different makeup or setup, and we need to ensure that we take those things into consideration. So that's a bit about us. What I'm going to do now is I'm going to hand you over to Brian, who will firstly introduce himself and then can take you through in a bit more detail what the system is all about. So Brian, are you there?
I am. Thank you, Phil. Yeah,
excellent.
Yeah, I think before I kick off, just a bit about myself, my background. I'm a medical HR manager by trade. So I've been doing medical HR since 94. Spent 12 years at Central Manchester as a senior medical HR manager, and then sort of went solo really. And I've been working across a range of projects. Initially, hospital at night, piece of work that I did for the Greater Manchester SHA, as it was known then. But certainly over the last 10 years, I've been predominantly working around sort of job planning, so workforce planning for senior medical practitioners. I was an associate with Four Eyes Insight for 3 or 4 years as well. For those that are familiar with them, they specialise in productivity, in-session productivity for theatres, outpatients, endoscopy, etc. So I was the job planning lead for them, and I still occasionally do pieces of work for them. I've been involved in job planning for AHPs. I'm familiar with health rostering as well. I was the health roster lead for Nightingale Northwest in Manchester. They're the sort of COVID hospital when that opened. But the sort of the big thrust, or the big sort of piece of work that I've been involved in over the last 10 years is around job planning and trying to get trusts to a point where they've got something sensible, and you know, they're in a position where they're getting annual agreements with their senior clinicians. I'm probably privy to about 4,500-5,000 job plan agreements in the UK. All facilitated by myself, and you know, linking in with senior clinicians, etc. So you know, I'm very familiar with this territory. I have been working alongside SARD for the last 9 months. We had a conversation towards the end of last year, I think it was, and I said, look, really, the big elephant in the room is team job planning. Nobody is assessing what the demand is on senior clinical time, and understanding how that converts into PAs, and understanding what the overall demand model is on a clinical team. I've been doing a bit of this using a spreadsheet workbook for a number of years, and I think the potential to, or the option to digitize it and market it to trust was, you know, clearly very exciting. You know, and we've developed something with the coders, which we've been working on over the last sort of 7 or 8 months, which I've also tested with 5 clinical departments at Barking, Havering, and Redbridge in East London. So you know, we've tested the system, and we've got outputs from that. And we're continually building it as we speak. You know, it's in prototype at the moment, but there was another tweak that I needed to build into the system this morning, so I was onto the coder, and those changes have been made already. So it's fairly fluid, and it will be what, even after we've gone to market. I think, you know, it's important that we take feedback from clients, and we're able to embed those improvements into the system where we feel that it's of value to trusts. So I'm just going to talk briefly. I'm just going to quick presentation about team job planning itself. Just bear with me a second. I need to get to slide 1. Okay, let me just. Whoops. So this will take me about 5 or 10 minutes. It's just to sort of talk you through the concept, really. You know, I presume you'll all be aware of the NHSEI advanced levels of attainment around job planning, and you know, I've seen data from NHSE in the last couple of weeks, and a significant proportion of trusts are still at level 0. That means that they're using they've got a paper-based approach to job planning. Level 1 is where you've procured a job planning system to manage the capacity part of job planning. So agreed job plans with clinicians, and if you've got a system but it's not fully functional, and you've not got good levels of compliance, you tend to sit at level 1, and there's a significant number of trusts, probably about 25%, that are stuck at level 1. There's a small number that are at level 2. To get to level 2, you need to demonstrate that 95% of your clinical workforce have annual job plan review, and those job plans are agreed. But level 3 talks about team job planning and capacity and demand analysis. Whoops, trying to move my slides on. You know, and team job planning isn't a new concept. I mean, it was technically formed part of the 2003 consultant contract. So it's been around for nearly 20 years. You know, even 10 years ago, NHS employers and the BMA waxed lyrical about team job planning and service objectives in their joint document. And very few trusts have successfully implemented team job planning. I think there's only one trust at level 4 in the UK, technically at the moment, the Royal Orthopaedic Hospital, And I think there's maybe one or two other trusts that have started to tackle capacity and demand. There's a number of reasons why this is important. For me, there's no point doing the capacity piece and agreeing a set of job plans if you don't understand what the demand is on that service and how you're going to wrap the resources that you've got available to you around that demand model. You know, as you'll be aware, post-COVID and in fact pre-COVID, most trusts have got backlogs for elective work, and a lot of them are pulling together elective recovery plans at the moment to try and deal with I think it's 7 million patients that are waiting for an elective appointment of some sort, whether it's in a clinic or diagnostics or in theatre. But if you can tackle team job planning, you understand the demand model that you've got, and you wrap your resources around that, you attempt to, it will inform you about what you need to do in terms of resourcing. So do you need new consultant posts? Is there a different skill mix? New ways of working that might enable you to meet that demand, and it'll also set out whether you're able to meet commission services, and will also if capacity doesn't meet demand, you're going to be reliant on bank and agency and contingent workforce to try and deliver the work, and it will give you some visibility of what that run rate's likely to be for the over the course of the following 12 months. So these are the levels of attainment that I've just basically talked you through, and my view is that team job planning will enable trusts to get to level 3. Okay, and it'll give you a significant potential to get there. This is what I think levels of attainment should look like. Actually, level 0, no team or individual job planning, and actually level 1 should be team job planning. I think job planning needs to start with the demand model itself. Okay, and so you need to develop the demand model first, and then you need to wrap your resources around that and go through an individual job planning process, and then once you've done that, assess the difference between capacity and demand and understand what's actually going on, and then you would go through a sort of resourcing and workforce requirements process to understand what you need to meet the demands on the service. And then there'd probably be level 5 where you'd operationalize that. Once you'd agreed the plans, you would operationalize that through rostering, and you'd have some system of measuring the delivery for each individual doctor. So if they've signed up to 42 clinics on a Monday morning, you should be able to track that to ensure that they're on course to deliver that in the current financial year. For me, this is the process, and team job planning and job planning both feature in this diagram. So you determine your demand model, you'd have service data that you would input into the system, you'd agree that model with the team, and also agree the approach for individual job planning. You'd then go through the job planning process in draft. You'd carry out a capacity and demand analysis, and you'd assess the alignments. And if there's absolute alignment, then great. Not likely in most cases, but you'd agree the job plans and you'd publish a team job planning report. If they're not aligned, there may be tweaks that you could make to individual job plans to improve the alignment. You may get full alignment through that process, amending the job plans, rerun the capacity demand analysis, and then formally sign off the job plans. Or you may not be able to reach alignment because you clearly haven't got sufficient resources available to you to deliver the work. And that would open up conversations about what you need to do to resolve that in the short or medium or even long term. And the demand model, which I'm going to give you the demonstration shortly, there's a range of inputs. Sorry for the spelling mistake on the right hand side there, but there's a range of things that you would input into the system. So you'd set up your service objectives, you'd put in the current staffing, you'd summarize the issues to resolve this year through the job planning process, and then you'd put all the detail in, including your sort of patient demand for outpatients, theatres, procedures, diagnostics, the current scheduling that you've got in place, what you're putting in tariff-wise for clinical administration, any emergency or acute or ward-based models of care that you've got, including Encore, MDT provision, other direct clinical care. You'd also, in the team job planning system, build in the demand on non-clinical PAs as well. So core SBAs, the tariff and approach, lead roles, PAs for educational supervision, appraisal, anything that people are delivering externally or through the local medical school. And then there's also an option to put in some in-year service developments that are already in plan. So you might be developing a new clinic or a new pathway, and the impact that potentially may have on job planning. And there's also a function to put in your current waiting list usage in terms of the number of lists, the reason for requesting them, and the cost of those lists per calendar month, to give you a sense of what your current run rate is on contingent workforce. And then the system will then develop a demand model for you. It will tell you how much your staffing roughly will cost you, current staffing arrangements, and how many PAs you need to deliver on the clinical demand model and the non-clinical elements of the team job plan. So I'm now going to just take you into a system demo. I've literally got 25 minutes to do this, so not much time, but this is the demo version of the system. It's actually based on real data at the trusts that we've tested it with. And you can see here I've got a range of toolkits in here. So I've got 2 for elderly medicine. I've got 1 for emergency medicine, gastro, obstetrics and gynecology, ophthalmology, rheumatology and urology. And they all work in slightly different ways, which is why I was keen to test them across this sort of broad range of specialties. So I'm just going to take you into the rheumatology one first, because they're fairly straightforward in terms of how they're structured. So you've got the setup arrangements here. So in here you can put in your toolkit users, so you can confirm who they are, whether they've got read only or full edit access to the plan, and you determine the toolkit modules that are relevant to this particular specialty. So clearly staffing and key issues would be mandatory. They're mainly an outpatient service. Okay, they don't do theatres, they don't do minor procedures or diagnostics. They don't have a bed base as such, so they haven't got any sort of ward-based models of care in place. They do MDTs, and then all of these other things are mandatory. So the SPAs and non-clinical things, they're all mandatory. So you determine those for each specialty, and then they're populated down here for the ones that you feel are relevant. So you're able to put in the staffing, so you confirm who they are, whether they're substantive or contingent, their grade, where they're based, whole-time equivalent, the contract that they're employed on, their PAs, on-call supplements if they receive them in pay. You can put in contingent staff as well. I don't think I've got any in there. They're all substantive. All of these names are anonymized. And in the outputs part of the system, it will determine for you what the PA allocations are by grade. Okay, and then what the costs are by grade and by location as well. And then you have a tabulated version of that below, which shows you what the overall staffing model will cost you. The costings are based on midpoint of the current scales for medical and for agenda for change, include on-call availability supplements, additional programmed activities, and 23% uplift for on cost to cover off national insurance contributions from the employer and the superannuation contributions. Okay, you've got the option here to put in some key issues. This is just basically boxes with narrative. So key issues to resolve in this round of job planning. It might allude to sort of improvements in the way that the job planning process is going to be carried out. It might allude to things that you want to put in place in this year's round. So in this service, they want to put in an advice and guidance facility where they'd allocate 2 hours per day, where a named doctor would would liaise with GPs and discuss potential referrals. You can put in your departmental objectives. And clearly these would cascade down into the job planning system that you've got. So you can put those in using the SMART approach to objective setting. In the outpatient demand, you would put in the details of the different clinics you'd run and the number of referrals that you're expecting per annum. So in this unit, I think they they take roughly 45 new referrals per week, and they're reflected in these numbers here for GP referrals and referrals from other parts of the service. They may be consultant to consultant, for example, and the number of follow-up patients that they expect to see in a given year. You can build in, oh, sorry about that. You can build in your backlogs as well. So they've got a backlog here on new patients of about 2,700 and 1,000 follow-up patients. You build in your consulting time for a new and follow-up patient and your current DNA rate. And what that data set does, it will set out what your outpatient demand is effectively based on the number of patients and the consulting times that you've put in. So you can see here they've got a demand for roughly 60 PAs for general clinics, 5 PAs for injection lists, 3 PAs for, there's 2 injection lists there. They've got a much smaller PA demand for EIA clinics. They've got in-session admin, which they've determined at 30 minutes per clinic, and they've got subsequent admin, which they've determined at 2 hours per clinic. Okay, so that gives you the sort of the PA values per week. Those values are based on a 42 attending week average, because that's the basis on which we job plan consultants. You've got a tabulated graph here that shows you the patient numbers, new and follow-up through each clinic. And then this gives you the tabulation on the calculations for the PAs. So these are the PAs in total for the patient-facing element of outpatient work, the in-session admin that's allocated within each outpatient session, and then the subsequent admin. Okay, so roughly a total of about 110 PAs in the okay. You've also got the ability to put in the current schedules for outpatients. So this is a breakdown of all of the clinics, and if I just open one of them up, it shows you where it is, when it is, what it is, who's covering it, and how many clinics that individual is going to cover per annum, and the split between new and follow-up. So 0 new, 8 follow-ups. Okay. You put in the day, the start time, all of that data. So effectively what that's telling me is that individual there is a clinical nurse specialist. They'll attend for 44 weeks, typically, not 42 like the consultants. They're gonna basically chip off of the demand 44 times 8 follow-up patients. Okay, so you build all of your current scheduling into the system. And you can see here there's a heavy demand on outpatients. There's a long list of clinics that they need to deliver. Also at the bottom here, you set your tariff for in-session admin and subsequent admin. Okay, so it's 2 hours for these clinics, the subsequent 1 hour for the injection lists. And what the system enables you to do is assess your current scheduling against your demand. Okay, so what this is effectively saying is that I need a PA adjustment in the scheduling to meet the demand on this service, and it's quite high. We've got 28 PAs we're short on the general and rheumatology cover for this department, and we've got some sort of more smaller numbers here. But with the PAs comes the admin as well. Okay, in fact, that doesn't include the admin actually. That just covers the PAs for the clinics. It shows you here the numbers. In fact, does that include the admin for the? That does include the admin as well. Sorry. Yeah. So you've got the total here that you need, which includes the patient-facing, the in-session admin, the subsequent admin, and then the total number of PAs that this service potentially would need to meet the demand. Now, this department is, I think it's the 4th busiest rheumatology department in the UK. And what the analysis here shows, and I'm not going to go into too much detail, is that by and large all of the demand for new patients is met almost 100% by the consultant body, but there's a significant shortfall on the follow-ups. Okay, about 6,500 patients, and the bulk of the follow-up work is actually not delivered by consultants. It's delivered by clinical fellows, clinical nurse specialists. So they may not need to invest in 29 PAs of consultant time. It might actually be, 29 times 4. What's that? Roughly, 3 or 4 whole-time equivalents by expanding their clinical fellow or nursing establishment. Okay. We've then got MDTs. So we've got the, where is it, what is it, when does it take place, who attends, and in there you would also, confirm when it happens and whether the consultants get any time for preparation and feedback as well, in advance and after the MDT. You've got the facility to put in other DCC. So in here they've built in the advice and guidance that they would like to put in place, which is 2 hours per doctor. There's 9 consultants, so 4.5 PAs for the team. Ward referral work that they do. So rheumatologists typically do some ward provision. They'll get a call from an inpatient ward, an elderly ward maybe, and asked to attend to review a patient that's got a sort of a rheumatoid sort of problem. You build in your core SBAs, so you confirm the tariff that you've got under your trust policy. And this trust actually prorate SPAs for people who are less than full time. So we just confirm here what the whole time equivalent is and what the prorated allocation would be. You build in your lead roles. Who covers appraisal? So the name of the doctor, how many appraisees, and the tariff per week. Anything that you've got in for external duties and medical school. There's some additional stuff that you put in as well around what you put in the educational supervision. So who is it that's covering it, how many trainees, and what's the tariff per week? And there's also a facility to put in your current audit, governance and research activities. So your annual audit plan, the projects that you've got running, who's picking them up, the amount of time per week that they need to deliver that audit, and whether that time is incorporated within core SPA or whether it attracts an additional PA allocation. You can put in all your governance meetings in terms of when they are, when they happen, and also any approved R&D funded research that you've got in place and who's picking that up, and the PA allocation for that and where it's funded. You can put in your planned service developments. There's a range of things that they were planning to do in this department. So the development there and the impact on job plans potentially. And then you've got your waiting list. There's no data in here because they don't book any. But you can put in your waiting list numbers, number of lists, and the cost per calendar month for RTT, 18 weeks, vacancies, absence, on call or other. And then you also summarize the private practice. So the individuals that are doing private practice, what it is, when they do it, and the frequency of that delivery. Okay, this is really an outpatient based service. So it's not as complex as that maybe a surgical service, but what it will then do in the DCC requirements, it gives you the sort of the breakdown of what you need on outpatients. So this is the patient-facing, in-session admin and subsequent admin, and then the graph, what you need for MDTs, other DCC, gives you the total number of PAs that you need per week across the team, and then it breaks it down here. Okay, and then it also includes the non-clinical requirements based on the data that you've put in. So it'll confirm how many PAs you need for core SPA for the different grades, appraisal, so on and so forth. It also gives a costing, an estimated cost per annum based on the midpoint of the relevant scales for the people who are participating in that. And then we have sort of the demand dashboard, which I think will change, but this just summarizes. You can export this to PDF, but it summarizes what this individual department needs in terms of PAs. We're going to make that more interactive, to be honest with you, but it's sort of the first iteration to give you an idea of how that works. I'm just going to take you to a more complicated specialty. So let's look at ophthalmology. And as you would expect in ophthalmology, they have outpatients, but they also have theatre demand as well. Again, most ophthalmology teams don't have inpatient bed base, so there's no consultant models of care. They do MDTs, all of the other things are mandatory. So in the theatre demand part of the system, there's a couple of things. Probably scroll down to the bottom first. What trusts would need to do to establish their theatre demand? Well, one, they need to determine the typical list duration, which is 4 hours in most trusts. So they put in 4 hours here. They've also assessed what the average turnaround time is per list. So this is the turnaround between patients. As one patient leaves the theatre, there's a bit of time in between before the next patient comes in. You know, they need to clean the theatre and prepare it for the next patient. So in this specialty, we've established through the data from their CareFlow PAS system that the average turnaround time per list is 20 minutes. And on average, they're not utilizing 30 minutes of the list as well. So effectively, they're utilizing 3 hours and 10 minutes with 20 minutes of turnaround. They have 30 minutes of pre and post-op allocation per list as well. What they've input from their CareFlow system is what they anticipate is the demand for the different things that go on in that specialty. So you've got the theatre name, the location, and then the procedure. And there's 1,000 per annum cataracts that need to go through the cataract list, and they on average take 36 minutes per case. Okay, and then you've got ocular plastics and lids theatres, and then there's a range of things that go through there. Again, the same process. And then you've got further down, you've got sort of general ophthalmology lists, and again, a range of procedures. And they actually do some cataracts in those lists. So there's what's the word I'm looking for? There's dedicated cataract lists, and then some of the cataract provision, almost a half of the total annual, is delivered in a mixed list, a general ophthalmology list, effectively. Okay, you're able then to put in the theatre schedules. So this is showing where it is, when it is, the list, and the number per annum. Okay, and you just confirm the consultant that's picking that up. So they do that on an alternate week basis, 21 weeks per annum. Okay, when we get to the theatre demand, it's taking all of that detail that we've put in to the input part of the system, and it's showing us how many patients need to be seen in each theatre, the number of lists per annum that would need to be delivered to meet that demand based on the on the time that's available to operate and the length of the case. That magically appears, it matches the PAs per annum, and then the PAs per week that need to invest to meet the demand on that cataract theatre, 4.5 PAs per week. We've got the same numbers in for the other theatres, and then we've got the pre and post-op as well. So it's telling me that we need 15.6 PAs per week in job planning to meet that demand. Okay, it also gives you a much more detailed breakdown by procedure. Okay, the numbers when you top them up clearly would come out the same at the bottom, but it's effectively telling you how many PAs per week you need to invest in for the different procedures that this specialty carries out. It doesn't include the pre and post-op. This is just the procedures themselves. It would then carry out an analysis of what you've got in scheduling compared to what the demand is on the service. And there isn't a great deal of difference, actually. They're probably, in scheduling, they've probably got 0.64 of a PA more in scheduling than they need based on the demand. Okay, as you can see the demands here. This is the scheduled PAs. These are per annum, demand PAs, scheduled PAs per year in the current schedules, and then the surplus. So the 32 PAs per annum over, which equates to 0.642 PAs per week based on a 42 attending week job plan. Okay. So again, in the demand dashboard, clearly we've got some stuff in for theatres here. It's broken down by the type of theatre, and we've got pre and post up in there somewhere in the mix as well. I'll just take you through urology because they're much more complex than any of these departments. They do outpatients, theatres, procedures, diagnostics. They've also got a model of care. They have like a consultant of the week, and they do MDT. So I just wanted to show you the consultant of the week module. The minor procedures and the diagnostics, they work in the same way as the theatre module works, but the models of care arrangement. Effectively, what they've got in place at Barking is they've got a duty urologist who works weekday at Hospital A, Monday to Friday, 8 till 5. It's done on a 1 in 9 basis. It runs over a 9-week cycle, and they have one individual covering that work at any one time. And the 9 of the individuals, they cover the model off 100%. Okay, the reason for having that in there is because if you look at an elderly medicine team, for example, they may participate alongside consultants in other specialties to cover off acute medicine. So they might have a 1 in 10, but there's 4 doctors in elderly medicine that cover off the acute model. So they would only cover off 40% of the model. So it's important to get that percentage right. Otherwise, there's a potential to overestimate the PAs that are needed to deliver it. They've also got duty urology at weekends, which is Saturday and Sunday, 9 till 3. Again, a 1 in 9, one person covers it. And then in addition, 7 days a week, they have the non-resident Encore, which they've estimated requires 2 hours of consultant input per night. Again, a 1 in 9, one doctor rostered to cover that each day. They cover off 100% of the model. So in the outputs for that, it will summarize how many PAs you need. So it's got each of the elements here, the PAs per shift, the number of days that it's functional. So weekdays, 260 days, 52 times 5. The number of PAs required per annum to deliver that. The PAs required per week based on a 42 attending week model. And then that's then shared between 9 doctors, equals 1.5 PAs roughly per doctor per week. Okay, and that overall model, it requires over 1,000 PAs per annum, 24.6 PAs per week, 2.74 PAs per doctor. And what we understand as well, one of the key things is that because when they do this, they don't do their elective work. So if you think about it logically, I think there's 52 weeks in the year, and if there's 9 consultants, they're going to deliver 5.78 weeks of this each per annum. Some will do 5 weeks operationally, some will do 6 weeks in a given year, but the average is 5.78 weeks. So when we look at the scheduling, and I'll just take you to the outpatient scheduling if I can find it. In fact, no, I'll go to the theatres, it'll be a bit easier. So you can see here, we've got this consultant here that does a Monday list, inpatient list on a Monday morning between 8:30 and 12:30. They're not going to deliver 42 of those. Okay, the reason being that they're not going to deliver that list every week, because there's 5.78 weeks when they're actually the duty urologists are on a hot week. So the numerator is reduced to reflect that. So the PA values that come out of the schedules reflect the actual delivery after you've taken into account the hot week delivery for the duty urologist. Okay. I think I'm going to stop there, because that's sort of a very, very quick overview. Clearly, for those that are interested in seeing it in a bit more detail, clearly we can do that. But I suppose I'll just open the floor up to questions, if that's okay.
Yeah, does anyone have anything they want to ask Brian about what they've seen, or if your trust is slightly different, how that would operate within your organisation? Feel free to pop your hand up or just ask away, really. If not, I assume Brian has eloquently described the system.
Got a question there from Liz.
Liz, yes.
Hi, yeah, thank you. I mean,
Hello.
It looks hugely impressive and very complicated. So yeah, I mean, well done. I'm from a mental health trust, and I think our revalidation managers on this call. So our needs are very different to what you've presented. So I'm just kind of wondering how it will fit. So basically, we only use SARD for our medical staff, not all of our other staff. So we wouldn't be using it for to kind of look at overall demand and capacity. All other staff have a separate job planning system, which isn't linked to SARD, so I'm just kind of wondering how that it can link.
Yeah.
I just made some notes. Let me just look at my notes. Yeah, also, I'm just kind of thinking, we wouldn't, so I'm the deputy medical director. I wouldn't possibly know all of that information. I don't think, I don't know who would, about all of the medical staff, what their private work sessions are, and everybody kind of essentially manages their own diary. So I don't know how we would be able to have that oversight, and it would be for our use. I think it would be much more about individuals doing their own job plans, and I'm just wondering if that would be possible within the system, just for kind of individual job plans.
Yeah, I mean, we clearly there's a couple of things. Clearly SARD have got a job planning system where you can build in the capacity for each clinician. That's available. We are in the process of, we're going to be starting working with Oxley's, and we're going to be rolling out team job planning there. Now they provide mental health services, but they also provide other community services like sexual health, diabetes. And I've worked with mental health, done quite a bit of work with mental health on Hospital at Night, and looked at models of care, ward-based, front door, outpatients, and we are mindful that at the moment we may not in this system have captured the things that typically happen in a mental health setting. So you've got tribunal work, you've got mental health act work, you've got some of it's community based. You'll have outpatients, you'll have consultant input into the ward provision for an acute mental health ward, dementia ward. You've got liaison, crisis resolution, and a range of things. But you should be able to, although there isn't good stuff coming out from the college at the moment, at least not up to date in terms of based on acuity, what's the sort of tier 1, tier 2, and tier 3 input that you need into an inpatient ward to make sure that it's resourced safely and sustainably. But we are going to be building that module with Oxley's, and we would be willing to speak to other mental health providers to think about how you can, what model do we need to put in to ensure that we can reasonably assess what the demand is on senior clinical time across the mental health services. What I would also say, because you talked about linking in with other job planning systems, and it's one thing I did forget to cover. If you've got the job planning system, the SARD job planning system and the team job planning system, that's going to be pretty straightforward to do the capacity demand analysis. But I am mindful that trusts have got they've got the job planning system, so Allocate, IT, Premier IT, and L2P. But there will be a functionality within our system once you've drafted your job plans to pull that raw data set out of the job planning system that you've got, so that our team job planning system can carry out the capacity and demand analysis for you. So it is our intention that will be sort of stage 4 of this toolkit. So you don't necessarily have to have SARD job planning system to be able to carry out that process. Although if you do, clearly you'll have direct links, and it'll be much easier to do so. But yeah, hopefully that answers your question. Sorry, my voice is going. I'll just take a glass of water before the next question comes in.
Yeah, can I just quickly come back? That's really helpful. So essentially, could you sort of tweak the system to match the needs of an individual trust?
Yeah, of course. Yeah, I mean, you'll have a sense in mental health of what you need.
Yeah.
Sort of inpatient wards, liaison, your assessment wards, before they take up a bed, if they take up a bed, all of the community-based work, the liaison around that. You should be able to build up a sense of what you need. You'll have data on your outpatient work. So how many clinics are you running? How many patients are booked into those? What's the typical length of the consultation? It'll be longer than 10 minutes in mental health. I know that for sure. But but you should be able to, from that, get a sense of what you need clinically, and assess that against the aggregated capacity in your job plans once you've built the job plans. It's not absolutely precise team job planning. It can't be. Things fluctuate, don't they? operationally, but it will give you a sense of what you need resource wise to deliver your service sustainably. I think that's the aim of it, really. You know, and then you'd operationalize your job plans, hopefully through a formal sort of e-rostering system, where you've got the ability to track the delivery of that across the course of the year. And there'll be trends, you know, so there may be increases in the mental health provision that you need to provide because of trends across, you know. So when you do it the following year, you'll tweak the team job plan to reflect what you anticipate is going to happen this year. It may be different from the previous year. You know, and then you'd go through that whole process again. You know, you need to do it year on year, really. You need to have a clear understanding of your demand and understand what capacity you've got and what the size of the gap is at the beginning of each financial year, I think, to inform you about what you need to do around your resourcing.
Okay, but thank you.
I think Karen and then Michelle, if that's okay. Karen, Asher.
Hi.
Hi.
I think, Brian, you might have answered some of my questions when you were just talking to Liz, because one of the things I thought at first is I assume you need your job plans, your individual job plans, to be in place to make this work.
Not necessarily, no.
Okay.
My view, I mean, I've done so many job plans, and I think one of the issues with job planning at the moment nationally is they're all done in isolation of each other.
Yeah.
And it's almost like a sort of a personal wish list for the consultant, dare I say, for a lot of them. This is what I want to do. And really the starting point should be for the service to establish what it needs.
Yeah.
And then you share that with the wider clinical team, and you would say, look, this is what we're charged with delivering this year, and this is how we're gonna, and we need the job plans to reflect that as much as possible. Now, you may not have sufficient capacity to deliver it, but at least post draft of the job plans, and then you marry that data off against the demand model, you should be able to establish the size of the gap across each of the different things that you do. And it should be that way round. But if you've got a strong set of job plans and you've got a perception that, look, we deliver the service in a sustainable way, then you could flip it over and use that data within the job plans to establish a demand. But I think, in my view, is the two things should be separate.
Okay.
You know, I think you need to build your picture on demand first, and then wrap the aggregated capacity plans, the job plans around that as much as you possibly can. Yeah, I think that's a better exercise, really. You know, a better workforce planning exercise to truly establish what you need and what you've currently got.
So just two more things really quickly, just to check. You can use this for overall capacity, not just doctors, can't you? Yeah, thought so.
Yeah. I mean, the current iteration is mainly for doctors and clinical nurse specialists that provide, you know, sort of senior cover either in outpatients, maybe ward-based provision as well. But we are aware that we need to consider this for ward-based nursing, potentially in community-based nursing, and AHPs as well. Now, the system at the moment isn't set up to manage AHPs, but I'd see their demand model being separate from the doctors in many respects. I mean, they're part of the multidisciplinary team, and there'll be some crossover, of course. But by and large, you know, so I think the intention is that we would offer this up as an option for nursing and AHPs as well. Yeah.
And just finally, I was thinking as I was watching it, I wonder what would be needed in terms of resources in the trust to deliver this effectively.
Yeah. I mean, there's the system.
Yep.
There's a range of inputs that need to go into this. Now, if you're using Rio, which I think you're a mental health trust, I presume you are, there will be data sets out of that's going to support you in terms of establishing what you need from an outpatient perspective. There should be data on bed usage, length of stay. You should have a sense of what you need across nursing and medical to service your wards effectively. But I think as part of this offering, I mean, we've not really sort of formally decided how we would roll this out, but I think initially, if customers are interested in this, there'd be the software itself, but there'd be support from myself and others as well to enable you to get it off the ground and implement it effectively, and make sure that you're getting the right data sets in from the sort of the patient administration systems that you've got in house. You know, it's going to be data from that really that's going to drive this, and you know, and enable you to take it forward. Yeah.
Okay, brilliant. Thank you very much.
Okay.
Yeah.
Anybody else?
Michelle did have a hand up. Let's put it down. I don't know if it was because we've answered the question already.
Yeah, just to quickly step in, thank you. I think you've answered most of my queries along the way, but I just wanted to say the system itself looks fabulous, very detailed. But in a similar situation, that we're a mental health trust as well, and at the moment I sit purely within the medical directorate, so we deal with the medics on L2P. Not sure that any of our other staff groups have job plans anyway on any system, so it's something that I'm going to take back and have a look at. But yeah, I think you've answered most of the queries, because I know you mentioned clinicians, and obviously some people say clinicians when they mean medical, so I just want to clarify what kind of groups you mean when you say
I think
clinicians.
this system currently is set up to handle consultants, specialty doctors, provision provided by clinical fellows and junior doctors in training, and clinical nurse specialists as well, you know, who more and more now are picking up some of the work that was traditionally picked up by doctors. Yeah. So it covers off those staff groups at the moment.
Right.
But there is an aspiration from us to, as I've said, you know, to extend that to sort of less senior nursing staff, and also AHPs as well. Yeah, I mean, I suppose I will say this. I mean, I know the other providers well, you know, and I've worked with the Allocate system for years in job planning, and I've seen their team job planning system as well, and I do know for a fact that none of the other providers have developed something as sophisticated as this. I think demand modeling is going to be difficult at first, but if you've never done it, it's going to be tricky, which is why I'm on hand to support you with it. But once you've mastered it first year, it should be easier in future years. But for me, it's the big elephant in the room. It's the big piece of the jigsaw that's missing around robust workforce planning. Yeah, for clinical staff.
It's going to require conversations within the trust as well to get the buy-in from the non-medical side as well, and to do it collaboratively, because otherwise at the moment what we have works for us, and but if it's just for medical and swapping like for like, I'm not sure that it would benefit us. But if it's going to be collaborative across the trust, then that's definitely something that we can take back and have conversations about.
Yeah. Okay, thank you.
Thank you.
Is there any other questions before we wrap up, or is everyone satisfied with what they've seen? I mean, if there are any follow-up questions you've got, please feel free, as I say, to reach out. We will reach out to you, all the people that have been on the call. Make sure that this webinar is available if you wish to sort of show colleagues. But if you require a sort of further in-depth conversation, almost on a one-to-one basis, just get in contact with us. We'll make ourselves available to talk you through. As I mentioned at the beginning, the official launch will be around November, but the picture you've seen today is essentially a comprehensive one, but a start. There are going to be other iterations as we move through, working with Oxys, as Brian mentioned as well. So if there are no further questions now, thank you, Brian, firstly, for taking us through that. And thank you to everyone who attended today. I hope you found it useful, and we look forward to speaking to you all in the future. So thanks for your time and have a wonderful day.
Thank you. Thanks for listening.
Thank you.
Cheers.
Thanks, all. Bye-bye. Bye.